Now, from my colleagues on Radio Taifa, we now shift gears to health matters. I mean, today being a Tuesday, we normally let you know stuff on health issues, and that is what we will be doing in a moment's time right now as we get to tackle a topic that is very, very important, that is fibroids. Did you know that statistics shows that about 20 to 80% of women get to develop fibroids by the time they get to age 50? Yes, it is one very common condition, and for that reason we have a doctor on set just to get to know what exactly fibroids are, what are the causes, what are the treatments that are available. We have Dr. Wachira Murage with us. He is an obstetrician gynecologist. Welcome to the show, Dr. Murage.
Thank you. Thank you so much for having me. My name is, as we have said, Dr. Wachira Murage, obstetrician and gynecologist at the Savannah Hospital. It's a pleasure to discuss this important topic that brings a lot of women to see us, brings a lot of stress and a lot of thinking about their reproductive issues. So this is a very, very important topic, and I'm happy to discuss it this morning.
Always a pleasure to have you on board. Now let's just get straight into it, and let's begin with the definition. What exactly are fibroids, uterine fibroids to be specific?
Thank you. Uterine fibroids are growths that occur in the uterus. Sometimes you can have parasitic fibroids, which can move from the uterus to other tissues. But the basic component of the uterine fibroids is abnormal uterine tissue that grows in a kind of a circular manner and to form a mass. So you can say uterine fibroids are related to the uterine tissue. They can be within the uterus, and they can also go to other areas like in the gut or in what you call the fat of the abdomen. But basically they are restrained or constrained within the uterine tissue.
So they are growths.
So they are growths.
But they are non-cancerous?
And they are non-cancerous. The only time we associate fibroids with cancer is beyond menopause. Because uterine fibroids are dependent on hormones, i.e. the estrogens. So the woman gets to go towards menopause, and they pause, the periods pause, no, they're in menopause. So there's no longer that hormone component that stimulates the growth of fibroids. So they should technically disappear or reduce to a very, very, very small size. But if you get a resistant sort of fibroid, which is painful, at that period of post-menopause, then we tend to worry, because there's a cancer called sarcoma, which are very, very aggressive cancer that sometimes can be confused with uterine fibroids. But basically, uterine fibroids are not cancer.
All right. What causes them?
The uterine fibroids is just hormonal. And when you're talking about uterine fibroids, you say that the cause is not known. And therefore, you talk about risk factors. The risk factors for uterine fibroids. Some of the the risk factors for uterine fibroids are like, number one, obesity and BMI. So there's a tendency for the ladies with high BMI beyond 25 and above, up to what we'd call morbid obesity. They tend to have uterine fibroids. Why we think there's that association or that link is because the extra fat in a woman is converted into estrogens, and those estrogens stimulate the growth of fibroids in the uterus. And why we are saying in the uterus is because there are things called receptors. In areas where there are fibroids, it has a higher concentration of those receptors of hormones. So when the hormones come into the blood and they're absorbed, that area tends to grow faster than the normal tissue of the uterine fibroids. And that fast growth is always abnormal. So that excess fat in ladies with the high BMI is converted into estrogens. And then those estrogens are then stimulate more that uterine tissue, and therefore there's causation of uterine fibroids. Of course, other factors are women who smoke also, they're related to uterine fibroids. Family history of uterine fibroids, we tend to get people running in, that kind of,
so
your mother, your auntie had fibroids. So we think there's a genetic linkage to the causation of uterine fibroids. But generally we say we do not know what causes uterine fibroids. Of course, they are more common in ladies who have early menarche. They start their periods early, all right? So that's now exposes them to a higher reproductive age, higher hormone output. And those ones that extend their menopause. So they'll have a longer, transit time when there are hormones coming up.
Yeah.
So the ladies also who stay for long without having their first conception, their first baby. Why are we saying so? It's because the uterus stays a bit empty, so there is that unopposed exposure to the hormones. And that, of course, now causes the growth of the uterine fibroids. So generally, those are the risk factors, because we do not know, we cannot nail down and say this is now the cause, but we find it's associated with those several factors.
All right. Yeah. Maybe what are some of the symptoms? How can one know whether they have fibroids or not?
Yes, thank you so much. As I go into, so that you understand better the symptomatology of uterine fibroids, fibroids have types.
Okay.
And you can have fibroids that are outside the uterus. They are called pedunculated. I talked about parasitic. Somehow that the uterine tissue went to an area far from the uterus. Pedunculated is linked to the fibroid. It has a pedicle, or like a stalk. Yeah, and then you have the fibroids that are within the wall of the uterus. They're called intramural. And then you have fibroids that are protruding from the wall. They're called subserosal. And then you have other fibroids that are within the wall, the lining of the uterus where the baby stays. And those ones are called submucous. Okay. So some of the symptomatology are linked to those types of fibroids. Of course, now, like the parasitic, you'll be far away, so it can cause a side of a mass effect where it is, pressure effect. Then you have the pedunculated that can even go to a point of even causing uterine intestinal obstruction, because the intestines can coil along. So you have seen patients who come with intestinal obstruction, the surgeons are not understanding. Maybe the fibroid, the pedunculated fibroid, has caused that kind of coiling on that pedicle of the uterine fibroids. Then you have now the subserosal, the ones protruding, they can be very, very big. Until you find like a woman is pregnant, even carrying twins, because of their size. Because where they are on the outside wall, they tend to extend further. By and large, the submucous are the major cause of what you call the symptomatology of uterine fibroids, which is heavy menstrual flow. The lady you come on, as they come see the doctor, they say, oh, it's been very, very heavy periods. When my periods start, they're heavy, they come in clots. I have to use several pads. I cannot go to work. I have to look for medication. That one we call it menorrhagia. Then, of course, there is the pressure effect that we have discussed. If a fibroid is on the we call it anterior, the front part of the fibroid. The bladder is just next there. So you find those women, you'll be peeing a lot, because there's the uterine fibroid, especially the subserosal, the one you have described, protruding out. You press on the bladder, so when you feel like peeing all the time, running. And when they go, maybe no pee comes out, maybe a few drops, and then they are done, but they'll continually feel a pressure. The same thing, if the fibroid is located on the posterior, the back side, it will press on the rectum. So the lady will be feeling like, they want to go for poo-poo most of the time. But when they go to the toilet, no poo-poo comes out. Those are, we call them pressure effects. Then, of course, there's pain. And the uterine fibroids, when they're so big, they do change. And it's called degeneration. Yeah, you can equip it to like rotting, because they're so big. So the blood, because they depend on the blood supply, is not getting into the core of the uterine fibroid. So that lack of blood there causes a lot of pain, and we call it hairline degeneration. So they also change in pregnancy as well. They also change. They become slightly bigger. They also become red, and they're also quite painful in pregnancy. They can be quite an issue in pregnancy. Those are basically the symptomatology of uterine fibroids. So most of the ladies who come because of uterine fibroids, they come because of the heavy menstrual flow or a mass. They can already feel a mass. And of course, those other things like the pressure symptoms and the pain follow suit.
Yeah. Can one have fibroids and not know about it because they don't experience any kind of symptoms? Can they be like asymptomatic?
Yes, yes. They can be asymptomatic. In fact, most of the fibroids are asymptomatic, especially if they are pedunculated, they are subserosal, intramural. So you find if they do not pain, they do not cause pressure pain, those kind of fibroids do not cause bleeding. Okay, so, you know, ladies, you stay for years, they are not feeling anything, but at one point maybe they have some pain or something, or they happen to do an ultrasound for some other reason. So the fibroids come in as some incidental findings. So there are many women with asymptomatic uterine fibroids. And for us as gynecologists, we are not bothered with asymptomatic fibroids. And we are normally reassured. We only come in quite aggressively if the fibroids are symptomatic according to the symptoms that you have alluded to.
And now that there are those that are asymptomatic, as you've just explained, what effect do fibroids have on the general woman's reproductive health? Like generally, what effects do they have on a woman's reproductive health?
Fibroids, we do not really blame them on general, the general reproductive aspect of the woman, but they can also be quite an issue, especially in infertility. They can actually cause infertility. And how do they do that? The fibroids that are within the lining of the uterus can affect implantation. Okay, because it's an abnormal surface that's there. So, and remember how conception occurs. There's depositing of the sperms at the vagina next to the cervix. Then the sperms will swim and they go to the tubes. The egg is picked from the ovary through the outer part of the tube, and therefore fertilization occurs within the wall. And then the fertilized ovum has to come into the cavity to look over an area where they can implant. So if they implant on the fibroid, generally they are going to get recurrent pregnancy losses, what you call recurrent abortions. So is that they reduce the space that is supposed to be occupied by the fertilized egg. The other way that they can affect generally the reproductive system is by compressing the tubes. Yes, like the pedunculated, like the subserous. Those ones can press on the tube, and therefore they cause kind of a blockage to the tube. Of course, remember, if they become symptomatic, the bleeding, the anemia, remember the fibroids, if they need surgery, surgery to the uterus causes trauma to the uterus. So sometimes you can cause adhesions, and adhesions you kind of block the fallopian tubes. That's the way generally that the fibroids affect reproductive system.
So it does not affect fertility. It just affects the woman's ability to carry the baby to term.
If you look at the causes of infertility in a woman, fibroids will not be number one. You talk about things like pelvic inflammatory disease, ovulation issues, hormonal issues, then you can talk of uterine abnormalities. When you're just talking about uterine abnormalities, that's when now you talk about the uterine fibroids. They contribute to the infertility by the issue of poor conception, space limitation in the uterus, and of course the blocking of the tubes to cause what we call tubal blockage, which is number one. But remember, tubal blockage, the number one cause is the infections, the pelvic inflammatory disease. But fibroids play a part in infertility. So when you're looking at infertility, when you're assessing a lady for causes of infertility, fibroids will not come number one. There'll be infections, tubal factor, male factor, hormones, then you come down to the uterine anomalies. When you're now discussing about the uterine anomalies, that's where the fibroids come in. So you can see they're not really a major cause of infertility. And that's why we advise the ladies that do not run to remove the fibroids because you're not getting a baby. Look at the other common factors and see which one could be contributing. In fact, we do even advise the ladies that before you go for surgery and you're looking for a baby, Yeah, get a baby first.
Oh.
Yeah, get a baby first. Why? When you're discussing the complications of surgery, and you're going to see when you come to the complications of surgery in uterine fibroids, you'll find that you can get endometrial adhesions. Adhesions are things like cobwebs that affect this nice flow of the tubes. So the tubes kind of coil, and when they coil, then that is they cause impediment of the transport of the ovum to meet the sperms. So we do tell them, guys, don't first go for surgery. Try and have a baby. Then when you have babies, then you can go and have this
sorry
surgery.
to interject, but what if the fibroids are inside the uterus? Would that cause a problem if they're big, maybe they're big fibroids? Would that interfere with the pregnancy?
If the fibroids are submucous, it will depend on the size of the fibroids. So you look at the size. In fact, as you are going to see when you're looking at the investigations that you do an MRI and assess how deep are they into the cavity. Okay? Because if they are less than 1/3 into the cavity, then you do not have to bother, because then they leave enough space. But if they are large and they are occupying most of the uterine cavity, then that is likely to affect implantation. And then, of course, remember, if they are big and they're in the cavity, the lady is already bleeding. Yeah, it's already bleeding, and therefore you have to go in for surgery, which is normally a very, very, intricate surgery, because if you interfere with the cavity, then you cause what is called uterine synarchy. The cavity causes adhesions, yes, and then the cavity can actually close down, and then you have another issue. There will be pain during periods. There will be no periods at all when you have that, and of course the cavity is closed up, and therefore there can never be any implantation. So that's why we say, let us assess, let us give time for the lady before we think of surgery.
Okay.
Yeah.
Okay. So what does the size of the fibroid maybe say? Is it possible for them to just be small ones and not grow over time, or it's dependent on time as well, or what causes the enlargement of the fibroids?
As long as the woman is in the reproductive age group, 15 to 49, the natural history of the fibroids is that they tend to be bigger with the time. They tend to be bigger. But what determines is from person to person, looking at the risk factors, the obesity, the lifestyle, okay? How old, the age, because the age is very important. Because if you're more than 35 and you have never carried a baby, the uterus has been free for unexposed or uninterrupted, exposure to the hormones. So they tend to have uterine fibroids. So it depends from person to person. There are ladies, they are 45, no children. They started their periods at 12 years, and now they are 45. They're still continuing. They have very, very tiny fibroids. You can get a young girl of 20 years, 18 years, she has huge fibroids that are causing bleeding and pain, and therefore they have to be operated. So it's normally individualized. It's from person to person.
Yeah.
So you can't say there are any other extra factors apart from the association of the risk factors, the age, and the genetic composition of the ladies. Yeah.
Can they just disappear?
At menopause.
Oh, okay, before menopause, is it possible for them to just disappear?
They can't disappear.
Yeah.
As long as they're in the reproductive age group, 15 to 49, they always grow bigger.
Okay.
It is the rate of growth that varies from woman to woman.
Yeah.
Some will be very fast. In fact, we see scenarios of where we operate a lady, and within another 2 years, 1 to 2 years, they are back.
Yeah, I actually had a question on the recurring of the fibroids.
Yes.
Because for most people, after even the surgeries, they still get them, like they keep recurring. Is it that the moment you get fibroids, then it means you will forever just have them until maybe menopause, as you've said? Is that the case?
It varies. It varies from person to person.
What causes the recurrence?
It's just the hormones. Just the hormones. And of course, when you're doing the surgeries, Remember, you don't do any scans intraoperatively when you're in theater. It all depends on the feel. Okay, so that of course the bigger fibroids, you go to the next. As long as you can palpate, you can feel the fibroids, then you can go for them. So even at surgery, it is not possible for a surgeon to say they have done 100% removal of uterine fibroids. They'll leave smaller ones. But remember, those for small ones you keep growing.
Yeah.
So you can say the issue of recurrence depends on person to person. It also depends on, you know, the quality of surgery at the time, and many other unknown factors that cause the recurrence. But generally, there are ladies who get fibroids until finally, even before they get children, they can't bear it anymore. They have had, you know, 2-3 surgeries, and it's very complicated. There are adhesions, and you find some ladies actually losing their uterus even before they get children.
Yeah, that's the myectomy.
Yes, the myomectomy.
Myomectomy, yeah. Before we get into the treatment options, maybe are there lifestyle changes that one can make and that would enable them to be able to shrink the fibroids or dissolve them maybe?
Yeah, that's a good question. But there are really no known, you know, 100% lifestyle changes. But of course, we say, look at your lifestyle. If you are smoking, you know, try see how you can stop, because it affects. Issues of exercise, all right? Because you want to get your BMI to the range of 18 to 25, okay? Because the extra fat will definitely affect you. So the diet, a good diet is very, very important. Of course, and then of course, as they say, okay, you know, the wellness, being happy, avoiding stress, because of those generally now, you know, the bad hormones coming to our bodies, they affect our metabolism, and therefore, you know, there's more fat deposition, and therefore extra hormones. So those are the things I would say would help to reduce, but definitely there's no 100%. I cannot fail to mention some ladies who have come and they have said they have used alternative treatments. You know, these products that people are using these days, we call them alternative treatment to the conventional treatment.
Yeah.
And they have mentioned a few products, and they have said, oh, when Daktari, you know, you remember last time I was bleeding, I had these fibroids, and I've used this particular product. And now, Daktari, I'm not bleeding.
Products that are not medicinal?
They are not medicinal, but you know, they are in the space of the natural products that are being marketed there.
Can we call them that?
And those other alternative treatments that people are using these days, you know, the supplements and all those. Maybe there will be a need for the doctors to work with those people and see whether those particular products actually work. But you have had a few women who have come to tell us, yes, this happened. Yeah.
Oh, and you examine and find, and you realize that for real it's...
Yes.
Oh,
yes, yeah,
that's interesting.
Yeah.
Some say that eating citrus fruits would help shrink them, eating apples, taking the intake of milk, and so on. Yeah, that's falls in the space of the balanced diet. Yes, the balanced diet is composed, of course, of you know, the fruits, the vegetables, and the proteins, and a bit of less carbohydrates. Yeah, but that's why I said we probably would need to look at those products. When you talk about the conventional space, the doctors, you find, you know, research has not supported, you know, the eating of those. But, you know, again, balanced diet helps us, you know, to keep our BMI in check, help us to keep healthy, helps us to distribute the fat, the digestion of food, and therefore reducing fat deposition. So that's the way we can explain those people who claim that such you know, fruits and other things have helped them sort out the fibroids. All right, I want us to get into the treatment options available. What are some of the treatment options available? And I want us to start with the non-invasive ones that you don't need surgery.
Okay, thank you so much. As we get into the treatment, how we get into the treatment is that we diagnose. We actually now think of what's all this from the history that we have described. Then we do things like ultrasounds very, very important. A very good ultrasound really is the main diagnostic tool. Okay? And before you go to the ultrasound, of course, as doctors, we examine. Yeah, so we examine and be able to feel that mass that is in the uterus. We do what is called bimanual, you know, examining from the private area and examining from top, then you can feel. Then you can do ultrasounds, you can do MRIs, some x-rays you can do as well, and then they can help you. When you're discussing uterine fibroids treatment, we normally want to start with, as you have said, you know, non-invasive. You can actually do conservative treatment of uterine fibroids. Conservative means you're just following the lady, maybe some painkillers, maybe you can give some blood builders. Okay, so it's called conservative. And as long as they're not aggressive, you can conservatively manage the uterine fibroids. Then you can come to medical. And medical, there are some drugs that we can give, both oral to swallow and then injections. And then important about the medical is to discuss the side effects, because they normally give the ladies menopause-like symptoms. They'll start sweating, they'll start, you know, having hot flashes, you know, they can have, you know, skin and vaginal dryness. So it's important to mention those side effects, because they can take a toll on the lady as they are taking the medications. The only thing we also discuss about medications is that it is not curative. It is just buying time, because what do? They shrink the fibroids. Once you stop the medications, the fibroids blow back and then continue growing. So you're saying the medical is when you're thinking maybe the lady is anemic, you need to boost the HB. So you can use the medical to reduce the size of the fibroids. Okay, as you're building the HB, then you can go to a more durable kind of an option of treatment. So that's what we like discussing. All a lady is around 48, 49 years. You can use the medication as you wait for the lady to go into menopause, and therefore the fibroids will shrink naturally. Yeah. Then you can have X-ray, radiological, so where you use X-rays. And then after that, then you go to now the surgical management. And in surgical these days, you have the minimally invasive.
Okay, I'll cut you short. Let's take a break, and then when you come back, we get into more of the treatment options for uterine fibroids. Welcome back. Thank you for staying with us. This is Health Check right here on Good Morning Kenya with me, Vivian Degwa, and I am joined by Dr. Wachira Murage, who is an obstetrician gynecologist, and we are discussing uterine fibroids. Now, before we took that break, we were just talking about the treatment options, and you had mentioned about the non-invasive ones, whereby you take some tablets maybe, and you've mentioned that these tablets may have some really tough, let me use the word tough, some really tough side effects, you know, menopause-like side effects for the lady. So my question was, if the fibroids are asymptomatic, as you had mentioned before, aside from them just growing, maybe it's just the mass that one can see and tell that truly I have fibroids, but they don't excessively bleed, they're not in any pain, would you still advise them to take medication, or it's just fine, you can just stay without it?
If the fibroids are asymptomatic, means they do not have the symptoms. So normally we'll advise the lady to just go conservative. But there's one element the ladies don't like, and that is now the cosmetic bit of it. The fibroids can look really big. Until you see the lady is slim, they have done their exercises, but they have a pot. And to an extent, sometimes they are congratulated that, oh, you can see there's something coming on board soon, so when is the day? Of course, that now embarrassment and of course that stigmatization and all causes the ladies to come, and that is an important symptomatology. Yeah, the size of the uterine fibroids. So we can remove them. But as long as the fibroids are not an issue, they're not disturbing, then we do not have to do any surgery. Because remember, or any treatment, because any treatment has complications. For example, when you're talking about the medications, the swallowing, Remember that they're swallowing every day. They're swallowing a tablet every day, every day. And of course, the side effects we have talked about.
Yeah.
And you're saying you're swallowing for about 3 months, because treatment for fibroids is normally between 3 and 6 months. That's when you get, good effect. So you can imagine the sweating. It's a young person, the hot flashes, the vaginal dryness. Sometimes libido is also reduced. Okay, sometimes you may have wrinkling of the skin. Sometimes you have some bone pains. Sort of like menopause. That's what happens. If there's the other formulation, which is the injection, they have to come every month for an injection. Yeah, at least the tablets are better because you can stop at a point. But the injection, and it has to expire because it's every month, every 30 days.
For 6 months.
For 6 months
3 to 6
or
months.
3 to 6 months. Yes, they come for the injections.
Okay.
They have some similar side effects. Okay, normally there are some anti-medication that we can help, I'll call them sort of hormone replacement treatment to try and counter those side effects. So for the ladies with such feelings, there are some medications that we can give. There are 2 types normally. A sort of natural soya-based medications, and also you can have hormonal-based medication. And now there are some that have come into the market, the hormonal-based, and they can quite do very well to counter those side effects of that. When you're talking about surgery,
when is it recommended?
The
surgery.
So surgery is normally now recommended when now bleeding is the commonest indication for surgery. When you have lots and lots of bleeding until the lady is anemic, because anemia, low blood, is a major cause. Is largely caused by the uterine fibroids because of the heavy bleeding. So that time the surgery is indicated. If the fibroids are huge, okay, and they can be seen, and the lady is feeling uncomfortable, then you have to operate. If the fibroids are causing a lot of pain, for example, so that lady at the time of periods, time of maybe even ovulation, they cannot go to work. The pain is so much, what we call dysmenorrhea, if it's coming during periods. Another time is just chronic pelvic pain. The lady is never at peace because of pain. Then you have to operate. If they're causing so much pressure, because sometimes they even press on the spinal cord, so the lady is always complaining of low back pain all the time, or they're complaining of constipation. Right? Every time there's that pressure, feeling of going to the loo. But because of the compression on the intestines, then there's a transit time for the stool to come down is delayed. So most of the water is taken by the body. By the time the stool is coming down to the rectum, it's a hard crust that causes constipation. And of course, the signs of constipation. They form hemorrhoids, piles, be very, very uncomfortable. You feel bloated all the time. Then you have to operate the fibroids. If they press on the bladder, so the bladder constantly cannot relieve the complete, there's no complete emptying of the urine from the bladder. So what happens? There is now more infections, more urinary tract infections. And more urinary tract infections, the lower aspect of the bladder can be managed, but the worst that can even cause an admission, can even affect the kidneys, is now the infection on the kidneys. We call it pyelonephritis. Okay? Sometimes they have caused even renal failure because the kidneys are not functioning properly because there is obstruction to the ureters and there is backflow of urine to the kidneys. And that can actually affect the functioning of the kidney because of the obstruction. We call it hydronephrosis and recurrent pyelonephritis. They can actually affect the kidney. So in such circumstances, you have to remove the fibroids. Again, if you do think the fibroids, according to the assessment, according to the HSG, to see whether there's obstruction to the tubes, then you see, of course, the lady is not getting a baby despite trying for about a year. You have ruled all other causes and you think it's the fibroids. Then you go for the fibroids and remove them.
All right. Well, when we talk about the surgeries, there are different surgeries for fibroids. If you can kindly just get to mention each one of them.
Okay. Widely or broadly, there are two.
Okay.
Okay. You can say the non-invasive and invasive surgery. When you're talking about the invasive, you're saying it's laparotomy. You're opening. Okay. When you now get into the uterus, then you can decide, and depending on what you have discussed, because when you're treating uterine fibroids, there's something called a consent, and this is very, very important. And I would advise the ladies to get full information from their doctors as, do you really need this surgery? Okay. What are the complications of this surgery? Okay. What will be your mode of delivery going forward when you have the surgery? Okay. Where are you? Do you need to remove the fibroids only, or do you need to remove
the entire uterus?
The entire uterus. So that discussion needs to be held even before, and the lady given time to go discuss with the family, digest the whole issue, because surgery is traumatic. Yeah. So you need to understand. Once now that informed consent has been received, that's when now you go into now the surgeries, the invasive and non-invasive. We were talking about the invasive. Invasive generally means it's open. Yeah. So that you go in, then you can remove the fibroids. And when you go in, you normally say remove as much fibroids as possible. One of the key preparations as you go into, especially the removing of the fibroids, is blood transfusion. Again, that has to be discussed. Yeah, because in the preparation for the surgery, you have optimized the hemoglobin. It's high. It's more than 10. You want it to be 12, 13, or more, but sometimes you can lose. Generally, removing the fibroids has a lot of blood loss. Okay? There's a lot of blood loss, and therefore you might need to transfuse. So that discussion needs to be held so that the lady understands there can be transfusion, and you know the meds about transfusion. Yeah? Then, of course, if it's a lady that's going to undergo hysterectomy, they need to understand. You're going for the hysterectomy, the uterus is a very emotive organ in a woman's life, okay? And therefore they need to understand, how does it affect sexuality going forward? It will be their pain. Do they understand that they will not have periods when the uterus is removed? That is at hysterectomy. But generally hysterectomy is for the ladies who are done with their child size, they are more than 35 years, they're happy, the fibroids are really disturbing, they're bleeding, they are a lot, you know. And kind of now that can be an option. Then of course you have the what you call the MIS, the minimally invasive surgery, where you just use some, we call them pots. We can call it hose for the sake of understanding. We call them pots, but hose, normally about 3, or they can be more. So you put in the cameras and you're able to see the fibroids. But for the minimally invasive surgery, the doctor has to assess. Yeah, because it's not all fibroids that are amenable for treatment with MIS. Okay, and in MIS you can actually do a lot. You can do the myomectomy to remove the fibroids. You can also do the hysterectomy. Yeah, during that time. So, but that's the way it's done. It's a good way, and as a lady, you should ask for that option. Whether you have fibroids, whether the state of your uterus allows for minimally invasive surgery. The beauty with the minimally invasive surgery is that it is cosmetic, because you're using pots. It's not a big
scar. It's not a cut.
Yes. Then the healing process is faster. In fact, you can do a hysteroscope and a laparoscopic, removal of fibroids, and you go home the same day. Whereas you cannot do that with open. Then, of course, the outcomes are normally better. The complications are less when you do the MIS. Then, of course, you can also do hysteroscopic. Hysteroscopic is how you're approaching from the vagina up to the uterus and where the fibroids are, and you can actually remove the fibroids hysteroscopically. Yeah, so those are the minimally invasive operations that you can do for uterine fibroids.
Yeah, I want us to touch on the complications, but before we get into that, very quickly, the cost of all this. Is it very expensive? And if you want to go for the laparoscopy, the one that is minimal invasion, or you don't get the cut, is it more expensive than the cut?
Very. It's a bit expensive, I must say, which is unfortunate, because it's only available in the leading private hospitals. Of course, in our national referral hospital, we have the laparoscopy where patients can use NHIF and other insurances. Because by and large, in the bigger hospitals, it can even cost something like 500,000 Kenya shillings, sometimes even up to 600, you know, especially for the myomectomy. Yes, let me say it's about, you know, anything 4 to even 600,000. So you can imagine,
expensive.
quite expensive
for the common person.
For the common
expensive
person.
Is relative.
Yes. Yeah. So for NHIF, yes, the National Referral Hospital has it, and other hospitals like our hospital in Savannah we have. And we've tried to, you know, to help in the costings. But generally, because of the machine that you use, and the other thing is, you know, you use gases, and then of course the issue about the minimally invasive, it takes time. An average of 3 hours plus. Whereas the open, you probably take 1.5 hours to a max 3 hours. But the minimally invasive 3-4 hours, sometimes even some people have taken 5 hours. So that's why the cost is normally a little bit high. Yeah.
But it's covered by NHIF.
By NHIF in the National Referral Hospital, it is covered. If they have to top up because of a few excesses that are unexpected, then they top up something little, 20,000, you know, 15, 30,000. But majority will be covered by NHIF. Other insurances also, they do cover. Yes.
All right. If you can, we are running out of time, but if you can just mention maybe the complications very quickly in the slightest of words. I don't know how that is possible.
The complications, you can have short-term complications, you can have long-term complications. Short-term is, of course, things like bleeding, injuring other organs. It has happened. Injuring the bladder, injuring the intestines, both open and the minimally invasive surgery. The immediate short-term, things like infections can come. Sometimes those particular wounds can also give way. They can give way, and therefore you have to go back to theater. Long-term are things like intestinal obstructions. They cause adhesions. Sometimes even infertility because of tubal obstructions. Yes, and then of course now the long term, with the lady that has been done myomectomy, the likely chances that she'll have a cesarean section. It changes the obstetric practice on that particular lady when it comes to the future. Like a cesarean section is normally the more common mode of delivery. Yeah.
All right. We really appreciate your presence, Dr. Murage. Thank you for just shedding light on uterine fibroids.
Thank you. Thank you so much.
You're welcome. This is where we put a cap to Good Morning Kenya this morning. I am sure that you have gotten to learn much about uterine fibroids, and for someone who's suffering from that condition, you've heard that it is treatable, so don't stress too much about it. Now, right now, I end this show, but remember, we are having the official unveiling of the candidature for the AAU chairmanship by Raila Odinga, and that will be happening, and as KBC will be covering that for you in no time now, because it is expected to start at around maybe 10 a.m. So keep it KBC for that and much more. My name is Vivian Dagwa. Until tomorrow, God willing, goodbye.